Hello, and welcome to the Adolescent Weight Loss Surgery, How to Get Them Through College session again. I will be discussing procedure selection and outcomes in this talk. I have nothing to disclose. As I recall, the first SAGES adolescent weight loss surgery session was in the mid-2000s. And at that time, we were debating whether adolescents should undergo on adults or should undergo adjustable gastric banding. And to the pediatric world, the band seemed to be a good option because the notion was we would put that in, the teenager would lose weight, and we would take it out and do no harm. Obviously, over time, for a number of reasons, there was a transition away from adjustable gastric banding in the teenage group, for the most part, not completely, to the gastric bypass, which was the gold standard in our adult population. More recently, as with adults, there's been a bit of a transition from the gastric bypass towards the sleeve gastrectomy in adolescents for a number of reasons. This graph in the bottom left simply reflects data from the Teen Labs study, which is a multi-center prospective observational trial that I'll discuss a bit more, looking at the operation chosen in the 5 centers who were participating in the trial. And as you can see, early on in the study, beginning in 2007, and then into 2008, the Roux-en-Y gastric bypass was the operation of choice. And then as we moved further into the 2000s, some gastric adjustable banding was used, as well as some sleeve gastrectomy. And over time, the sleeve gastrectomy grew in popularity amongst the surgeons performing these procedures. This is 2014 data, so to update us into 2020, here's a recent publication by the MBSA QUIP group, looking at almost 2,000 teenagers between 2015 and 2017. And you can see that the gastric bypass was only used in about 22% of these patients, where the sleeve gastrectomy was used in 78%. So the 2 operations that are most often used in teenagers are the Roux-en-Y gastric bypass, as depicted here, and the vertical sleeve gastrectomy, as depicted here. And we don't have time today to go into technical details that surgeons like to argue about at length, but these are the 2 choices, really. However, I do want to comment about adjustable gastric banding so that that doesn't feel left out completely. A recent publication in June of this year, again, looking at that small group of adjustable gastric bandings in the Teen Lab study. These patients were prospectively entered into the research protocol and followed for 5 years. So even though the number is low, the follow-up has been robust. The mean age is 18 years. More females than males and more whites than blacks. BMI was average of 49. At 5 years, however, the mean BMI decreased by only 3.3%, which was not statistically different than the baseline BMI. 43% of those patients had BMI values that exceeded baseline, and 21% of the bands had been removed at that point. So the remainder of the talk really will be about outcomes in adolescent metabolic and bariatric surgery. And we'll first talk about short outcomes and then what I'm going to call longer outcomes because we have no really long-term outcomes in teenagers. So again, the Teen Lab study is an NIH-funded prospective observational trial of 5 centers who enrolled 242 adolescents into bariatric surgery. I was a PI at the Children's Hospital of Alabama, and so that's my experience in this with this group. So this is the same slide I showed earlier, but just to mention that this was the initial paper from the Teen Labs group, really looking at perioperative outcomes in adolescents in the first 30 days after surgery, published in 2014. Again, this shows the rise in initially with gastric bypass and then subsequently a rise in sleeve gastrectomy. However, more specifically, here are some 30-day characteristics and complications that were published in that paper. I'll say that there were no deaths. There were 2 patients who actually needed anticoagulation therapy for possible pulmonary emboli. There were 2 patients in the bypass group who had gastrointestinal leaks that required operation. There was 1 patient who had suicidal ideation in the sleeve cohort. There were 2 patients that had leaks that required reoperation, 1 in the bypass and 1 in the sleeve group. 1 patient in the sleeve group required TPN longer term, and there were 2 patients that required small bowel obstruction operations subsequently. However, a more recent look at short-term outcomes in teenagers undergoing metabolic surgery is just published again in 2020, and these are data that I showed earlier as well. Almost 2,000 adolescents, mean age is 18, mean BMI is similar at 47.5. Interestingly, 78% underwent sleeve gastrectomy and 22% underwent gastric bypass. And to summarize the short-term outcomes, 30-day outcomes, serious adverse events were lower in the sleeve gastrectomy group compared to the bypass group. Readmission rates were lower in the sleeve gastrectomy group compared to the bypass group. The reoperation rate was lower in the sleeve gastrectomy group versus the bypass group. And they also compared these 2,000 teens to over 300,000 adults also in the database and found no differences in outcomes in the first 30 days. So this is an effort to start comparing results in teenagers to results in adults. I'm now backtracking a little bit and going back to something that I thought was important for us to learn about early on in the process of adolescent bariatric surgery. This was published in 2010. And basically, early on in adolescent and pediatric bariatric surgery considerations, everyone was afraid that we would be harming the patient more than helping. So there was a tendency to want to set the bar higher for indications for surgery. So rather than a BMI of 35 or 40, people thought that we should set it at a BMI of 50 or 60 and multiple complications. And so early on, we had quite a few teenagers in our cohort that started with a BMI of 75, another group sort of in the 60 range, and another group in the 50 range. And early on, none of us were doing bariatric surgery in the 35 to 40 range for the most part. But what we learned was if you started at a BMI of 70, 1 year later, you had about a 30% change in your BMI as it started to flatten out, your BMI change. If you started at a BMI of 60, a year later, you had about a 30% change in your BMI. If you started at a BMI of 50, a year later, you had about a 30% change in your BMI. So we learned that perhaps it was more reasonable and important, depending on the complication rate, to try to tackle teenagers who had complications of their obesity earlier rather than later, because the long-term results would be expected to be better if we operated sooner than later. So this, going back to the Teen Labs group, this is the paper published in 2016 on 3-year outcomes. Here we're looking at weight change from baseline on the y-axis. So if all the patients started at 0, and then we're comparing sleeve and bypass. And you can see the lines overlap in terms of weight loss at a half a year and at 1 year. They maintain that weight loss at about 30% of weight loss for both groups at 2 years. And then at year 3, there seems to be a slight uptick, but there's not a statistical difference between the sleeve and the bypass group. This is taking one comorbidity that we see commonly in obese populations, teenagers, and seeing if there was a difference over 3 years in sleeve versus bypass effect on prevalence of dyslipidemia. So at the beginning of the trial, before surgery, about 70% of our teenagers had dyslipidemia. And by 1 year, you can see that prevalence had dropped to 30 to 40% in both groups. At 2 years, they were very similar at about 30% prevalence. seem to be maintaining a significant drop in dyslipidemia, or the prevalence of dyslipidemia in teenagers who've undergone bariatric surgery. Now turning to, again, trying to compare adolescents to adults. That's a current ongoing discussion of interest. This is the teen labs and the adult longitudinal assessment of bariatric surgery study, pooling patients to publish a paper last year, specifically looking at gastric bypass 5-year results. So this is not giving us any insight into sleeve gastrectomy at this point, but it is robust information for the bypass group. Again, looking at weight change from baseline at the start. So we start at 0, and at year 1, both the adults in orange and the teenagers in blue lose about 30% of their weight at 1 year, very consistent with the 3-year data. Again, at 2 and 3 years, the two groups, the adults and the teenagers, again, are maintaining about a 30 to 25% weight loss. This carries out to year 4 and to year 5 at about 25 to 23% weight loss at year 5. So in terms of weight loss, no difference really in this group, in this study, between adults and teens with bypass. We also looked at some other comorbidities in this study, and so here we're looking at remission of type 2 diabetes, comparing adults and teens. And so the y-axis is percent of patients with remission. So at year 1 after surgery, about 70% of the patients, adults and teenagers, had remission of their type 2 diabetes. This maintained itself out to year 2 at about 70%. And then at year 3, there starts to be a slight divergent where the teenagers seem to have a higher level of remission of diabetes at year 3, 4, and 5 compared to the adults, who seem to be drifting down a little bit, and at year 5 have about a 55% remission of diabetes compared to 85% in the teenage group. This is looking at another comorbidity. We're looking at hypertension now between adults and teenagers after Roux-en-Y gastric bypass. Again, at year 1, the teenagers had about a 70% remission of their hypertension, while adults had about a 55% remission of their hypertension. And you can see that over time, over the 5 years, the adults dip down a little bit, and by year 5 have about a 45% remission of the hypertension, where the teenagers at year 5 were between 65 and 70% on average of remission of their hypertension. So perhaps a slight improved results in the short term over 5 years with adolescents over adults. So this just summarizes the studies that I've just mentioned: a significant difference in type 2 diabetes and hypertension in the teenage group, and a trend regarding dyslipidemia, hypertriglyceridemia, and low HDL in the teenage group that did not reach statistical significance in this cohort. Now, looking at deaths and reoperations carefully, comparing adults and teens, this was important information. There were 3 deaths in the teenage group and 7 deaths in the adult group. That came to about 2 deaths per 500 person years in the teens, and a little over 2 deaths in the 500 person years in the adults. So not a real difference between teenagers and adults in terms of death over 5 years. Intra-abdominal operations, the teenagers underwent 19.5 per 500 person years compared to 10.3 in the adult group. So it appears a higher rate of intra-abdominal operations within those first 5 years. And that may turn out to be true, although I will say the teenagers were followed very, very rigorously in the teen lab study, and it may be that more issues were identified. And specifically looking at cholecystectomy, 21 of the teens underwent cholecystectomy compared to 23 of the adults. But it is important to note that 9 of the teenagers underwent their cholecystectomy before bariatric surgery, not afterwards. So this looks more dramatic than perhaps it is. I know in my own practice, many teenagers get into our obesity bariatric program because they had presented with gallstones or cholecystitis, have a cholecystectomy, are identified as having a problem, and then are referred into the program. There were other morbidities, bowel obstruction, surgery for bowel obstruction in 6 and 7 respectively, internal hernias in 6 and 10, gastrostomy in 3 and 2, and others. So just as you eyeball this, there are not a lot of differences in complications or deaths between teenagers and adults. Now, to look at some more recent data, this was a just published paper in March of this year, again comparing adults undergoing both sleeve and bypass and adolescents, both about the same number of patients in the trial. The adults' average age was 47, the teenagers were 18. There were many more females in the adolescent group compared to the adult group. The heights were the same. The weights were higher in the teenagers at 141 kilograms compared to 127. And the BMI was much higher in the teenagers of 50.5 compared to 43.6. Now, the teenagers underwent, in this study, the teenagers underwent gastric bypass much more often than the sleeve gastrectomy. So we'll have to take that into mind as we go forward in looking at the data. So here is percent weight loss in the two groups. The adults are in the gray and the adolescents are in the black line here. And you can see that at 3 months, both cohorts have lost about 15% of their weight. Then when we get to 6 months, the adults have lost about 21% of the weight and teenagers 24%. And then at 1 year, there's more of a divergence, and the adults have lost about 24% of their weight, and the teenagers have done a little better at 30%. This is increased again at the 2-year mark, with teenagers losing 33% compared to the adults of 22%. And then the adolescents tend to parallel the adult line beyond 2 years with a little bit of weight regain, although at the 4-year mark in this study, the adults had lost about 20% of their weight, having put back on 5%, and the teenagers had lost about 29% of their weight, again, having put on 4 or 5% more compared to at the 2-year mark. Now, it is important to say that these differences are all significant, even if you adjust for the surgery, race, and baseline weights at all time points, other than the first one, which is not statistically different. This study also looked at the impact on comorbidities over the course of their study. And this is the proportion of individuals with resolution of 3 comorbid conditions. So in the looking at hypertension, 69% of the teenagers had resolution of the hypertension, consistent with the Teen Lab study. And the adults had a correction of about 35% of hypertension at their 4-year mark. In addition, looking at diabetes, almost 88% of the teens had resolution of diabetes compared to 55% of the adults. And then in terms of dyslipidemia, there was no statistical difference in the two groups, with perhaps an edge going to the adult group having remission of their dyslipidemia a bit higher than the teenagers. I'm now turning to another topic of outcomes, which is health-related quality of life type data. This is a paper from a long time ago. It was our early cohort of teenagers at the Children's Hospital about a health-related quality of life tool. Our teenagers preoperatively are in the blue line, with a normal health-related quality of life being at about 50%. You can see they range from 30 to 40% in these health-related quality of life components. The green line is a cohort of control teenagers and young adults that overlap with that 50%. And very excited to see that 1 year following bariatric surgery in the teenagers, even though they do not have a normal weight, their BMI has dropped by 30%, so they've gone from perhaps 50 to 35 BMI, they still perceive their quality of life to be significantly higher than pre-op, and also significantly higher than the 50% baseline. So very encouraging to see these teenagers clearly perceive a benefit from the weight loss surgery. This is a more recent study looking at anxiety and depression in a cohort of normal weight teens compared to 55 obese teens who underwent bariatric surgery. And in this study, the Beck Depression Inventory 2 was used, and the State Trait Anxiety Inventory were the tools that were used. In general, the obese group scored much higher than the normal weight patients for depression and anxiety. And this was the unfortunate result was that symptoms did not really improve after metabolic and bariatric surgery. I show this paper just because it's a future look at sleeve gastrectomy versus gastric bypass. This is a prospective study that is currently underway, so I don't have any results, but they'll be coming, and it's looking at teenagers between 13 and 17 who are randomized to sleeve gastrectomy or bypass, and the primary outcome will be 20% total body weight loss at 3 years and some interesting secondary outcomes. So we'll all look forward to having a head-to-head prospective randomized evaluation of sleeve gastrectomy and bypass in teenagers. Now, the other issue that has been of concern to us who have switched mostly to sleeve gastrectomy, as with adults, is what would be the impact of sleeve gastrectomy on gastroesophageal reflux and potential esophageal damage in Barrett's esophagus in the future. And we don't really have a lot of data in teenagers, but here are two recent studies where the question was, is there a value to a pre-op esophagogastroduodenoscopy in the teens who are being considered for sleeve gastrectomy to determine whether they already had significant risk factors for potentially Barrett's esophagus. So this study published just recently looked at 40 teenagers and young adults, and it found that 98% of the EGD had normal anatomy, and on biopsy there were only 12% that had some histopathology, and nobody had frank Barrett's esophagus. Another study published last year looking at 94 patients showed that only 7.5% had abnormal anatomy, and 38% did have some mild mucosal abnormality. So in conclusion, I believe that adolescent metabolic and bariatric surgery is a good option in select adolescents who have severe obesity and complications. Sleeve gastrectomy is currently the most popular procedure being offered. Compared to adults, adolescents lose similar, if not more weight. Compared to adults, adolescents have similar, if not better, resolution of select comorbidities that we discussed today at least. And compared to adults, complications appear to be similar. So obviously we need more long-term follow-up like the adults have, and these studies are underway. So I appreciate your attention, and thank you for participating in this session.